Well, welcome. If we can start, I would like to, please. All right. Well, welcome today. I'm Shirley Fenton, manager of the InfoNet Project and managing director of the Waterloo Institute for Health Informatics Research. On behalf of the University of Waterloo, we welcome you here today. Thank you for joining us as we continue our series in Health Informatics Tools for the Future. We also welcome those who are joining us via our webcast of this seminar. I understand that there are a number coming in. And just to note, we have an electronic archive of our events, which you can view 24/7 from the InfoNet website. So if you happen to miss, I can't imagine why anybody would miss these things, but if you do happen to, please know that you can see them later on. Special welcome to our speaker, John Glaser, who hails from Boston, Partners Healthcare, Inc. For those of you that think this winter has been unbearable, the good news is, I understand from John, that Boston has had it worse there. So how many inches of snow did you say you had? 52. 52. So I think we're actually in good form here. Before we begin, I'd just like to let you know about our next seminar, which is on March 23rd. Sarah Friesen will be our speaker. Sarah is General Manager of Shared Healthcare Supply Services for Sunnybrook and Women's College Hospitals and University Health Network, Hospital Network, and Mount Sinai Hospital. She's a leading North American authority on improving supply chain and materials management performance in healthcare facilities. I think it'll be a great talk. ORMED will be also sponsoring that seminar, so it should be a good event. We are also holding a health informatics and bioengineering career symposium for students and industry and healthcare organizations. That's on March 10th, 4:30 here. We'll start with short presentations, and following that there will be an information exchange over an informal reception. You can have a beverage of your choice, some nibblies, while you meet with others that are involved in healthcare. So if there are industry people here, healthcare organizations that would like to participate, please see me after this event. Special thank you to our seminar sponsors today, McKesson, VON Canada, and Healthcare Information Management and Communications Canada. Thank you so much for being our sponsors. With that, I'll introduce the person that will introduce our speaker, David Johnson, University of Waterloo President.
Thank you very much, Shirley. What a pleasure it is to introduce John and to welcome him here. Let me make a comment about the weather in Boston, John. This is a perfect example of redistributive justice. The gods that deal with important matters in life like sports and weather tend to be even-handed, and when the Patriots won the Super Bowl again, and when the Red Sox overcame the curse of the babe, those equal measure people felt that they had to visit something on you, and that's what they're doing. And if there was an NHL season, and it now appears that we're not, the Boston Bruins were going to win the Stanley Cup. Let me give you the kind of hard facts about John, and then let me just put him into a bit of a context, which is at least attractive to me. John, as you know from what we see here, is the VP and the CIO of Partners Healthcare System. Previously, he was VP Information System at Brigham and Women's Hospital, one of the outstanding hospitals, not simply in the United States, but in the world. And prior to that, he managed the Healthcare Information System consulting practice at Arthur D. Little, and on and on and on. The contextual remark is how lucky we are to have people like John as leaders in this field who provide such a breadth and depth of competencies. This is a newly emerging field, and in newly emerging fields, the leaders tend to be rather unique people, not simply people who are good at analysis, but people who are especially good at integrating. It's more than the Renaissance man kind of person. It's not simply a person who knows something about a great deal. It's a person who has that rare capacity of putting expertise and intuition and insight together from a number of different fields, and somehow having the consequence be a very powerful and not confusing consequence. At lunch today, I was sitting beside a PhD student, Paul Thagard. Paul is a professor of philosophy here who leads an exciting program in cognitive science in which he, a philosopher, has managed to bring computer and electrical engineers, Don, some of your old buddies in computer science together, and psychologists in a interdisciplinary cognitive science program. His PhD student is doing his PhD on what he calls Abduct of Logic. And as he explains it, it is that process of thinking whereby you draw generalizations from a set of hard facts or data that you know, and then you also have generalizations that you must draw from the absence of hard facts or only partially understood hard facts or data, and put those two together. That's abduct of logic. It's generalizations that come from only partial information. And really that's what we're looking at in this new emerging field of health informatics. I see it in several other ways. I have the good fortune at the moment to be a member of a task force put together by Minister Jerry Phillips, the Minister of the Treasury Board in Ontario, to review large information technology projects, large-scale projects. Ontario spends about $1 billion a year in information technology. It's had its share of failures, as many public institutions, many governments have. Perhaps the more spectacular one is the firearms registry system of the Government of Canada, where over $1 billion has already been spent on that large IT project without yet a result that works in any fashion. And Denny Desautels, the former Auditor General of Canada, chairs this task force. And you say, why would you have an Auditor General? Well, you have an Auditor General because he can provide a kind of rigorous oversight. But as we see the instances of successes and failure coming before us, there is such a very high onus on the quality of leadership of these projects. And what we find is that the successful ones have usually been led by people who have these integrative qualities that I've been associating with John and other leaders in the field. And that the information technology tool is typically not the problem. The problem is developing the business case or the understanding of the problem that is to be solved, and then the re-engineering of the culture around that problem that is necessary. And it means a very great deal of work has to go in at the front end to develop the business case, and then to establish the integrative leadership around that business case, and then put the information technology tool into it. It's kind of the reverse of what you'd think. Intuitively, you get the tool and then you redo the problem. It's the other way around. One of the people that has been very helpful to us is someone from my profession, a lawyer who writes a leading textbook on the management of information technology projects. And he tells us that one of the reasons that lawyers tend to be quite dominant as chief executive officers in the early stages of the entertainment industry coming out of Hollywood and Los Angeles through the 20s and 30s and 40s and 50s was that it was a new emerging industry, the entertainment industry. And it required this kind of intuitive judgment that you simply don't teach, has to come from experience. And typically you get it best by managing a significant number of very large projects and learning from the failures. And he said the lawyers had typically managed 20 or 30 or 40 major films or something of that sort before they began administering the whole enterprise. And today, he said, it's rare to find a public service manager of an IT project who's managed more than $100 or $200 million projects in his or her career. But you have someone who comes from a specialized profession, like the lawyer attending to this, who might have managed 30 or 40 and has learned a good deal from it. So that's a long way of saying, John, we're so pleased to have you here today. We're so pleased to have someone who reflects so well these rare and important integrative qualities in leading IT projects and leading this emerging industry today. And thank you for sharing your wisdom with us, as you will in a few moments.
Appreciate that. I appreciate those very thoughtful comments. I have to tell you, though, you guys know this too. I go to meetings for a living. So generally 7 to 8 in the morning to 7 at night, sometimes 2 or 3 nights a week late till 9 o'clock. So about 50 hours worth of meetings. That's all that I do. And I've learned two things. And I remember being instructed by the chief operating officer at the Brigham when I first joined the Brigham. This is 17 years ago is when I began my CIO career. I said, son, I'm going to teach you 2 lessons here. One is never write anything down because it'll haunt you, okay? So you can make verbal commitments and always deny them later on that you promise this or you promise that. He said, second, never leave a meeting with anything sticking to you, okay? So all the tasks have been distributed across all members of the meeting except you. And that's the way you'll survive going from meeting to meeting. So those of you who are having careers like mine or any management position, never write anything down, never leave anything sticking to you at the end of the meeting, and you can thrive for very long periods of time. So you're going to see the conclusion or the results of 17 years of avoiding work, which is fundamentally how that translates. I very much appreciate the opportunity to be here. I have known Dominic for 20 years in the profession and have enjoyed coming up here. Was with an AGVA conversation about a month ago, and for the last couple of years have been spending some time, maybe about twice a year, with the folks at the Capitol Health Authority out in Edmonton. It's been very interesting to learn both the similarities but also the differences between the respective systems, and realizing at the end of the day, healthcare and physicians are very complex and in fact has no boundaries that really are different by country to country. I'm going to, just a brief context on this slide is tell you a little bit about Partners Healthcare. We are a provider of care. So we have 10 hospitals. 2 are quite large. So the Massachusetts General Hospital, the Brigham and Women's Hospital. We also have the Dana-Farber Cancer Institute. A series of community hospitals ranging from 270 to 120 beds. We have about 7,000 physicians who work with Partners. Some are employed, most are not. We employ about 40,000 people. Largest actually employer outside state government in the state of Massachusetts. We're about $5.4 billion in size. We're very academic. And you'll see that because I think one of the things an IT group has to culturally fit with its surroundings. We do about $1 billion in biomedical research a year. We're also a teaching affiliate of the Harvard Medical School, but also teach nurses and all kinds of allied health professionals. So very large integrated system of care, integrated with a lowercase I, as you'll see here, that does a lot of research and a lot of teaching. And I'm responsible for the IT function within that. And I'm going to start here with just a couple of comments about the notion of themes as a basis of IT strategy. It's a little different than how we sort of normally do this, and then give you a series of themes at Partners. And themes at Partners, for example, work we're doing in genomics and understanding the genetic basis of disease and how this will influence the design of systems, work we're doing in managing medical knowledge, and work that we're doing in moving systems out into the outpatient sector. But so I'll give you some exposures of the work, but let me talk a little bit about themes. Those of you, and if you to the degree you've ever been exposed to this stuff, traditionally how do most organizations, including healthcare, develop an IT strategy? And it's largely a derivative process. You say, we have a strategy of disease management, whatever we think that might be, but we're going to go off and help people manage their diabetes, manage their asthma, congestive heart failure, et cetera. And given that, they then turn to a room full of people like us and say, what can IT do to help us? And you say, well, there's a bunch of stuff here you could do. You could put on an intranet best practice guidelines. You could have databases that look at patterns of care, of over-underutilization, good practice, bad practice. You could, remotely connect to sensors on people. There's a bunch of stuff that you can do. And then the real management conversation becomes, well, which ones are effective, which ones are not? Is there a normative sequence? How much can we afford? But there's almost a derivative of one way, this way. That's the traditional way. There's another basis, and you can get in a separate conversation of IT strategy and how to do that. But one very important basis that we use, which complements this, doesn't replace this, but complements this, is this notion of themes. And a theme is that an organization states relatively broad goals. An example, you see 2 examples here. Our goal is to improve care, the quality of care. Our goal is to reduce costs. And this is a goal that persists over many, many years. I mean, a decade plus, this goal persists. And the mix of things that they'll do on any given year can be different. So what we'll do this year to reduce costs will be different than the things that we do 5 years from now, and different again from the things that we do in 10 years. But what themes really help us do is to make sure that we create a critical mass of competency and talent. So if we say we're going to have people, for example, who are going to have to understand the role of genomics because is both for research but also the treatment of disease. We have to create a critical mass of talented individuals, resource fund them, because that talent and that know-how will be able to leverage over a range of initiatives and a range of projects over very long periods of time. It's not inherent when you go from derivative that you're going to focus on developing competency. It might happen to you because you get good at a series of things, but it's not inherent that competency will be the result here. So that's that notion, and then there's a couple of studies here, to the degree you want to go off and pull these out of the literature, which found and examined organizations that were very, very effective at IT over very long periods of time and looked at them. So why is that? What is it that they did? And one of the things that's consistent is that they have this basis of themes. So with that, I think there's a key 4 things you have to do. And frankly, I do some work. And one of the things that I do, it's rare, and I really try to avoid it because I get tired and, it's crabby sometimes, is that when you identify a theme, that in fact you have to make sure that you hire and retain and grow the talent and the competency. A lot of it is in IT, but not necessarily only in IT. That you have to be able to fund it on an ongoing basis. Now, it could be from operating dollars. It could be that the organization says, we're going to kick in this amount every year to fund this stuff. But increasingly, for us, sometimes it's mixed. It's from federal grants. It can be from industrial partnerships. But there's an inflow of funds, no money, no nothing, on a lot of these things. You guys know how the management mechanisms work. There's a way to guide what they do. And last but not least, there is an R&D component. And an R&D component says, no matter how good we think we are today, there's aspects of this we don't understand very well. And that if nothing else, the technology is moving, and if nothing else, the application of the technology may be limited at a level. So there's always an R&D component to that. So one of my jobs is, 1, identify the themes and make sure that these 4 things happen, and all of them. And there's times when you create these things, they're like little babies. I have 3 teenage daughters. They're actually beyond, they're 21, 18, and 15. And my deal with them, just those of you who are thinking of this along the lines, you got 2 options, kid. If you want to get married, I'll pick it up. Or I'll give you 10 grand in cash if you elope. And just let me be serious. I'll come out ahead on the cash. You might have a nice car. Hey, what's the deal with this? I might lose my marriage in the process. But anyway, that is the sort of deal with the kids at the point here. So, but nonetheless, these things often are fragile early and have to be nurtured for a while so that they get off to the races and thrive on their own, take their first steps and go on. Now, you'll see here, and I'm just sort of leading here, is that sometimes the themes are actually quite related. Patient safety. We want to be able to do terrific work in patient safety. Sometimes they cut across the initiatives. So with that as the sort of only management background here, these are the 9 themes that at this time and have for several years that guide the work that we do across partners. Again, we do a whole bunch of projects, but these guide them. I'm going to walk through them briefly. And I'm going to talk about the first 5, and largely because of time, because I'm not sure we can get into all those at any reasonable depth. We may not even get into, reasonable depth on these. One is that it's always terribly important that you have a very high-performance infrastructure. The servers, the networks, the operating systems that you bring to the table are very fast, they're secure, they're reliable, because this is the basis upon which things run. And so they have to be well done there. Similarly, they're phenomenally expensive. I mean, half of my capital budget, which is about $35 million a year, virtually half of it is consumed on infrastructure, the sort of normal refresh in advance of this kind of stuff. So that's one. The second is ambulatory care. Now, the math here is pretty simple. On an average year, we will treat across partners about 160,000 admissions. That's how many admissions we'll have. A little bit more discharges because babies come somewhere in between in some cases. 4 million outpatient visits that we see in a year. The inpatient volume is growing at approximately 3% a year. The outpatient volume is growing at approximately 9% a year. So this is where the action is. This is where the care is occurring. And if you look at any reasonable projection of the growth of the chronically ill, there is a like that's going to grow faster. And particularly as cancer progressively becomes a form of chronic disease, which it is becoming. And that you'll live well into your 80s, but having cancer for decades. And so we'll see more on the outpatient basis as a result. So a lot of the outpatient care. The third, for obvious reasons, and you perhaps have been exposed or seen the Institute of Medicine numbers about the consequences of medical mistakes. But that certainly has, and it's appropriate that it has done so, is put this notion of safe care, that we don't poison you by giving you medications, that we don't remove the wrong limb, or we do a variety of other things which can have quite fatal consequences. The next one here is clinical research, and we're big, as I mentioned, a big research enterprise. A lot of us at this point is really, and we'll see this is in the genomic realm. Actually, those of you, I go to a lot of meetings in which I'm surrounded by deeply talented, very smart people where I don't have a clue what's going on. I really don't have a clue. And the only way I know if I'm okay is if all the heads are moving in the same direction. So if everybody's doing this, we're fine. If everybody's doing this, we're fine. It's when there's mixed head movement, we got trouble here. Because they're all going to turn to me and say, what's the answer on all this stuff? Beats the hell out of me because I didn't track half this conversation here. You know, anybody got the lucky quarter? We'll flip for it, see who wins here. But anyway, one of the point for all this stuff is I used to think that telecom people had the best density of acronyms and the most complex diagrams I could ever see. I mean, unbelievable set of acronyms and complex diagrams, lines and clouds and lightning bolts and all this crap. I didn't know what it meant, but it looked complicated. No wonder it was expensive. The geneticists haven't beat hands down. No question on terms of acronym soup, fuzzy concepts, and impossible to read PowerPoints. The next one here is managing medical knowledge, which we'll see in a little bit, and it's what happens to you when you get to a place like we are at this point, and your organizations may get there too. We have inpatient, for example, provider order entry running at the two academics and the Dana-Farber Cancer Institute, about 26,000 orders a day entered by a doctor, and a lot of rules behind that, which is the real reason you would do this. Similarly, we have the electronic medical record used by about 2,600 physicians daily, and a lot of logic behind that. And so a lot of this is growth in medical knowledge and having to manage that. So we'll cover those 5. There are others of dealing with medical imaging, the phenomenal growth of volume of radiology images and types of studies, but increasingly, cardiology images, to a degree, stuff coming out of microarrays, mass specs, and things like that. Patient care workflow, just moving them through the house, whether that's the hospital or the ambulatory clinic, in ways that are efficient and reduce the need to build buildings and reduce the hassle on the staff who are required to deal with that. I talked about this a little bit at the AgFA, although I don't know that you were all here, which is delivering care over distance. And this ranges from second opinion work we do, where we do patients from Beijing, Riyadh, Sao Paulo, who are coming in to get a second opinion from an oncologist or a neurologist, to monitoring the congestive heart failure of Mrs. Smith, who might be 5 miles away from the Mass General. I'm just sort of monitoring that and delivering care over distance. And then the last one is probably perhaps most peculiar to the states, where you have the payers, the commercial payers, Blue Cross Blue Shield, Aetna, Cignas of the world, and a series of things that we're doing and to integrate with them, to remove some of the transaction costs and share clinical data. Depending on the Q&A time, we can come back to some of those ones that I won't specifically address. But let me talk with the first one here. Now, what I'm going to show you in the next couple of slides here is stuff that is more on the edge, rather than stuff you have to do every day to keep it up and running and working well. This is an unnecessarily complicated diagram, but if you're a CIO, you have to have at least 2 in every presentation to make it look like you're worth this amount of money they're paying you in the phenomenal budget that you command here. So what this is, I'll give you the punchline of this thing. Right now in Boston, Massachusetts, and virtually all regions in the United States, you can walk across the street from one hospital to the other and they don't have a clue what happened in the prior hospital. And so you can cross the street from the Beth Israel Deaconess Hospital, which is literally 100 yards away from the Brigham and Women's Hospital, and they don't have a clue what was done in either place. What's even striking is if you take the master patient index of the Beth Israel Deaconess and crosswalk it with the Brigham, there's a 38% patient overlap. Son of a gun. How about that? Walk across the street, how easy can it be? And yet for a third of the patients, they don't know what was done at the other side. So this is a creation, early forms of creation of infrastructure to link clinical systems in a region. And fundamentally, if you can do it in a region like Boston or a region like Atlanta or a region like, well, nothing gets done in New York City, but so we'll carve them out in Los Angeles because they're hopeless. But Chicago, you are in a position to link across regions. So this first form of this will be ready by August. And part of the both is this is where funding comes in. This is funded by the Markle Foundation and to a degree some of the participants. So you sit over here, you log in, you say, I want to, anybody out there. And so this is, I'm at Brigham and Women's Hospital. I want to know Boston Medical Center, Leahy Clinic, Winchester Hospital. I mean, there's 60 hospitals in the state of Massachusetts. Anybody know anything about John Glaser or ever taken care of John Glaser? And you enter into this utility. And this utility or set of services has a basic way of saying, I know all the John Glasers. They all have different medical record numbers. I can read this index, which is actually hosted in an ASP mode here, and issue the medical record request. Now, I have identified John's stuff at 6 places. and I send a message to these 6 organizations saying, I want to confirm John Glaser, white male, 49 years old, can't jump, that kind of stuff, never will be an NBA player. And it comes back and says, these 6 places have it. I then say, I'd like to actually request records retrieved. Non-standard at this point. It's pretty, it's almost PDF-like. But I'd like to see the chemistry results, the radiology reports, and it comes back and gets them again and sends them back to here. And it has a set of applications. I think you got to shake this thing a couple times to make it work on it. But anyway, that allow you to, over time, view problem lists, notes, review radiology reports, and eventually images, et cetera. And so this is a utility. The only thing that actually exists in the middle is going to be this. You actually have forms of this software as a sort of on a server on your premise that have some security here. And then to the degree one wants to talk to Albany, New York, or Chicago, Illinois, there are linkages here. There's a great deal of interest in the States to do this on very fuzzy data. Largely it's sort of BI, Beth Israel, Brigham crosswalk stuff. The other thing that we notice here is if you look at any projection of those who are chronically ill, if you have 4 or more chronic diseases, it isn't hard to get 4 or more chronic diseases. You could have high cholesterol, you could have a little blood pressure stuff, and man, you've got 2 already. But if you have 4 or more, on average, you see 10 different doctors in the course of the year and are taking 12 different medications. And by different, it doesn't mean there's a dose change, or it doesn't mean there's a refill. There's a dose or other new medication change. Now, question for all of you, when you have 2 doctors involved in your care, how well does the communication between them work? Not very well. How well will 10 work? Not at all. There's just too much going on. It's hard to do. So to solve problems that will go with the progressive increase in the chronically ill is the need to create infrastructure like this. We don't know how much this will cost to run. We don't know whether it will be economically viable in a sustainable business model in this sense, but let's get it up and give it a shot, and we will learn as we go forward. So we'll see early forms in August, and I suspect more piloting for the year beyond that. Next one here. And I'm badly colorblind, so these colors were picked by the lady sitting next to me on a plane flight last week who was sitting in 28E. If they look awful, you blame her, okay? Not me. She said, I got a pigeon in my hand. She doesn't know nothing about colors. But anyway, I can't tell them. But anyway, here's the deal. If you're at Partners Healthcare System, we have the Noah's Ark of computer rooms. We have a little bit of everything. And so we have Meditech, we have Siemens, we have some internally developed stuff here. This is a thing from Meditech, does for outpatient or nursing home stuff. All these quote stovepipes of applications. This is what we got. Now we got a little drug-drug interaction logic here, there's a little more drug-drug interaction logic there, and you can see multiple instances of drug-drug interaction logic, both different logic engines and different logic that goes across the board. They all share, some share patient database, some don't. They all feed this master EMPI and this master clinical repository. So you can look up Mrs. Smith's composite clinical picture, but if you're operating in the bowels of Meditech, you're unaware of data. You're aware of this data, but you're unaware of data that surrounds here. This isn't good. And so there's an intent to get consistency of one database and to have consistent logic and medical knowledge behind all this. Now, you say, I want to do that, but I don't want to replace this, because this is gruesome to replace this kind of activity. I mean, it's hundreds of millions of dollars, 5 years, high CITO, casualty rate. I still got another couple of kids to get through college. I'm not ready to go. So can we finesse this? In other words, can we create this consistency while preserving that asset? Is fundamentally the question. So this is what is being put together, where there is a service layer. We will excise, and I think there's going to be real limitations that we don't understand yet. Excise the drug-drug interaction, medication services, formulary shifting type stuff, common allergies for Mrs. Smith, notifying a doctor, maintaining problem lists. I mean, lots of different ways to spell diabetes. You all know that, or to express blood pressure. And then to move to a single clinical database. So what is being constructed, and we'll see, this is, I think, a neat model if we can finesse it, is that, in fact, data recorded here is posted here, and data recorded over here is actually pushed back in. And so you actually replicate the database across all of these platforms. The other theory is that you can leave Meditech to construct the drug-drug interaction software and come back. That's more theory than reality at this point. But part of the infrastructure is a service orientation of core knowledge services and data services to be inserted into this heterogeneity here to see whether we can get a step forward on integration and consistency without having to go through this gruesome exercise. Last one on the infrastructure is this sort of general noise and immaturity surrounding the wireless realm. I think actually, at least for me, although, I think this is at this point well enough understood about how to do it and what to do. It doesn't mean the technology is perfect here. What we are spending time is the role of RFID on tracking equipment. We lose equipment. It doesn't actually leave the hospital. It just sort of disappears. It winds up in toilets, and it winds up in closets. We even found some nurses in the Mass General who were storing it in ceiling tiles because they, when they run out, it's a painful thing to not find a 12-lead AKG or 12 leads or whatever. So they would hide this stuff. And to track equipment and to see whether, in fact, knowing where equipment is can lead to a capital expense reduction because you're not replacing stuff that you can't find. We also have trials that track some of our staff, so we know particularly when the developers are in the toilet too long, time to come out and return to the workforce. And we also, we're looking at OR teams, OR surgical teams, of tracking them because one missing person on the team and you've delayed a case. Very expensive to do. And we're also looking at the cellular phone, which may be the dominant device for reaching the patient in the years ahead, is the sheer number of cell phones, the growth rate of cell phones relative to PDAs, and the presence of advanced capabilities such as cameras. Some of you may have heard this, but I'll give you an example of a trial we're doing now. If you want a dermatology visit at the Mass General, 50 days from now is when you're going to see the dermatologist. Say, holy smokes, that's not good. What's clogging it up? What's filling the schedule here? An awful lot of routine acne visits. So we're checking routine acne. So we have a trial. You take the camera, you're 18, or however old you are, you take a picture of your acne using your cell phone camera, transmit to the dermatologist, they'll send you an IM or an email message saying whether there's a need for a change in antibiotic regime. Done. Get them out of the house, convenient for you. Blue Cross Blue Shield indicates some level of reimbursement, but experimenting with cellular technology in a wide variety of ways. These three are illustrative of this sort of theme and work that is being done here. Next one, outpatient care. Here, a little bit of a, part of the intent of the first couple of slides is sort of examples of stuff on the edge, at least the edge for us, and maybe you guys have got this nailed. Here, it's a little bit more of the types of activity needed to go on. We put systems out, electronic medical record systems out there, and it's a really hard implementation. I mean, it's hard to put these things in the middle of very busy physicians and nurses and disrupt the workloads. It's just a very difficult implementation. It's also an expensive implementation to do. On average, by the time you amortize the cost, it's 10 grand per doc per annum. It's roughly the carrying cost, take the fix and spread it, times 7,000 docs. This is a lot of money on a go-forward basis every single year to do this thing. You had better be sure you're getting gain out of this thing, et cetera. So what exactly do we want the record to do? Part of that requires that you have some good knowledge of what's broken about your own health care. So one of the IS groups that we have is composed of health services researchers who study care processes and what breaks. And we use that guidance to develop these systems. So here, for every 1,000 patients coming in for outpatient care, I'll give you a rough translation, 4 million outpatient visits a month, that's roughly 1 million unique people, on average 4 visits per. You take this number here, times 1,000 is our annual volume of what we're seeing here. So 14 are here with a life-threatening or serious, 14,000 per annum are here because of a life-threatening or serious adverse drug event related to a prescribed medication. We actually, for every 1,000 who come in, we admit 3.4 because it's that bad. We have to hospitalize you. For every 1,000 prescriptions written, 4% are medically wrong. You just can't give that dose. You can't give that route. It's not like missing units. It just doesn't exist as a prescribable event. This is the one that bothers me the most. If you're a woman with a marginally abnormal mammogram or pap smear, we know we should see you in 6 months just to make sure we're not heading in the wrong direction. Question, what percent of the time is there no evidence that we followed up at all? Nothing. I mean, there's nothing, no tests, no visit, no note, no nothing. Answer is 36% of the time. We have no evidence that we did anything. Now, maybe we did and we didn't write it down. Maybe you went to the BID because it's 100 yards away. We don't know. And then finally, if you are diabetic, you're at a bunch of other things. You're at high risk of high cholesterol. We at least ought to be watching your cholesterol, if not treating it. And yet 38% of the time, there's no LDL-C on record within the last week. We're not even watching this kind of stuff. This is badly broken outpatient care. And this is us. This is Partners Healthcare System and, surrounding community. Great docs, great places. Nonetheless, the systems stink. So why this is important when you're looking at a theme like this is a couple of reasons. You can imagine the IT response to this. Thing comes in, marginally abnormal, ticker, calendar clock goes off, 5.5 months later, it wakes up, says, I want to see evidence of a repeat exam, I want to see an evidence of a scheduled exam, I want to see an evidence of a scheduled appointment, and if not, I'm going to start paging you till you surrender, doctor, and do something about this kind of stuff. Similarly, if the system's aware that you have diabetes, it can remind you to collect the cholesterol. I mean, lots of very simple things to go off and do. So in this thing, very important to go after, understand where the breakage points are, to design the IT response to go after them, and then to measure, did you do any good as a result of this particular activity. And at times you find that you do well in some cases, but not well in other cases. So we have 12% of our expensive radiology modalities on the outpatient setting are the wrong modality. You just wouldn't do an MR, or you wouldn't do a CT, you would have done a different modality. Decision support to try and guide that, very problematic, because it, in effect, you put the physician in a very awkward spot about ruling out this or ruling out that, and a lot of our retrospective analysis indicates inappropriateness, but it can be prospective. And I mean, Ron knows this more than most. So we actually have people who write these systems. We are unusual in that we write our own clinical systems. We have developers who do this. The reason we do that is one is assuming you can do it and do it well, which is hard to do, is the preservation of agility. And we'll see an example of this a little bit later on, but as you discover, you introduce changes and then you discover problems, you introduce IT changes and you evaluate. Short cycle agility and learning is fundamentally what we're after. And here's an example of the sort of basic screen of this kind of stuff. If you've never seen an electronic medical record, this is what they look like. Really not very interesting. N means note. It's probably the only thing I understand about this whole thing. But you also have things, and it goes back to this sort of cholesterol test, here's my panel of diabetics and my sort of dashboard. How well am I doing at managing their LDL values or managing their blood pressures or managing their hemoglobin A1Cs? And so this becomes a response to managing a cohort of people who are chronically ill. And allows me to compare my panel, compare myself to peers, and then compare myself across partners. Last point here, again, this is theme-based here. This is kind of where we are. Actually, of the 7,000 docs, 5,200 are eligible for an electronic medical record. The rest are radiologists, pathologists, anesthesiologists, a different IT response. We're about halfway through, so 2,600. Nicely done on the AMCs, not so well done on the communities. The point of this is that if you look at, for us, the clinical systems theme and say, what kind of staff do I need? You need 4 kinds. You need people who assess the problem so they can guide the response. You need people who craft the response. They either buy it or they build it, but nonetheless they craft the IT response. You need people who, on a form of guerrilla war, put these things in every single day. And they know they have scar tissue all over their body because they survive multiple encounters in making this stuff occur. But a world-class implementation people who are incredibly strong and incredibly disciplined. And then the fourth, and we'll see an example of this, is people engaged in the R&D activity who look a little bit down in the future. Next one here, and this will be relatively brief because I think there's a lot of understood about what to do. It's still hard to do this. This is patient safety. So this is an example of order entry and an intervention that comes back, and you can see it as well as I can point to it. Then on the far left, there's an allergy detected to the penicillin family. And it's coming back and saying, are you aware that there's an allergy here, and what do you want to do about this stuff? To give you an example of the frequency of this kind of stuff, on an average day, approximately 4% of all inpatient orders are changed by the physician based on a computer suggestion. Sometimes related to patient safety, sometimes related to medication shift to a less expensive equivalent. But nonetheless, it's very clear, and you may have seen the Bates work, which became quite famous, that CPOE can have a major dent in medication errors and in taking down the 55% reduction in serious medication errors and an 83% reduction in overall errors. It's probably the frontline IT approach to all this. There are others, and one of the things here we're doing now is smart pumps. In other words, pumps that infuse and take into account the toxicity of the drug and information about you, the patient, and your weight, and the goals that we have in mind here. One of the things that this has done is brought us quite close to the biomedical engineering, clinical engineering community as we get sort of incorporate devices as more of what we do here. So here's the pump attached to this lady who's got a look of terror as she looks at her nurse about what's about to be done here. I don't know if you can see that from back there. I don't know why we use this diagram, this picture here. It's sort of the partner's way. If we don't cure you, we'll scare it out of you, okay? I sometimes think, and I was telling these guys, I'm like, you know, it's funny, we are so bad at service. It's amazing to me how bad we are at service. So I'll give you an example. In the clinics, we turn the phones off from noon to 1 so we can go have lunch. What's the deal with this? You know, when are you going to call your doctor? Noon to 1, one of the prime times to do this. What do you get? You get an answering machine. Hey, man, we're having lunch. We'll see you later. So we're so bad at serving, but you know what? You keep coming anyway. It's amazing. So one of the few industries where we can abuse you and you still show up. How about that? Service ain't us. You got to park, that's your problem. That's not mine. Take the bus next time. So anyway, here's this smart infusion pump, which is delivering medication. And there is a data set that has to be programmed with rule libraries and sort of configured to the device. And then we close the loop by looking at data about use of these things and potential mistakes that go on. A frontline approach, we don't have good data about the impact of this, of using the smart pump to remove errors associated with overdosing in IV meds, particularly chemotherapeutic agents and other toxic level agents. Our most recent one, and this may be too faint to see, is the medication administration record. And here there's a barcode on the wrist, you zap that, barcode on the drug, you zap that, barcode on your lapel, and you zap that using a handheld device, and you make sure we're doing the right drug, right patient, and we identify who's doing this thing. And that registers, and then you continue to sort of manage the medications that you're giving, whether TPNs or other types of medications, and then there's some allergy stuff. I think, frankly, on the inpatient side, if you're looking at patient safety, there really are 3 responses. There's order entry, the medication administration record, and smart infusion pumps. They're hard to get in, they're expensive, but there's not a lot of mystery about the answer at this point. You could argue some error reporting of sort of people recording areas that are other things. The outpatient side is a little bit more complicated still on the sources and the nature of errors, and which is why some of the studying continues to go on. Let me move to this next theme, which is genomic stuff. This is the only diagram that I have where the things move around. I didn't do this diagram. I don't know how to make things move around. I have little... Years ago, I'm going to be 50 this year. It's remarkable to me I'm going to be 50 this year. Those of you who are my age or perhaps a little bit younger remember slides and carousels, and you remember that. Those of you who are young, you don't know what we're talking about, so you can take a nap for the next 2 seconds here. I remember when I changed from slides to PowerPoints, and I thought, I'm a happening guy. I'm really going to make the big leap. It was very hard to leave the carousel behind. I mean, there was something about that carousel which was important to me. And it occurred to me after I was done, and a couple of PowerPoint slides, my presentations weren't any more intelligent afterwards than before. I was dumb before and I was dumb after, okay? So nothing changed there. Second, like you saw in every slide leading up to this, pretty damn static. Flash 4 bullets, maybe a screenshot. Flash 4 bullets, maybe a screenshot. Pretty like a slide. This is exactly what it was. So what the hell have I done? All I have done is I'm just as dumb, they're just as boring. I've now increased the likelihood that it's going to break because I've introduced this variable here which breaks with great frequency. Plus I've made it more expensive. I've got to buy this variable here. So it's like IT in general. You put IT in, nothing's different. It's just less reliable and more expensive. And so it's a great metaphor for IT in general here. So I got this from somebody else. I'm not going to take credit for this. We start, and here I think this is I look at these themes and I say they all have different challenges at this point in time. I look at patient safety and I say, we know what to do. It doesn't make it easy to do, and maybe this isn't we have money to do it, but we know what to do. And there's enough experience now to know what to do here. If I look in the ambulatory care arena, it says we're getting better about what to do here, but we're still learning about how screwed up it is and still designing applications here. Here in this realm, we say I have 2 audiences here. One is the immediate investigator, the person who's looking at the genetic basis of disease. And there's a lot of people looking at the genetic basis of disease. I mean, it's an important research component. I'm sure it is here. It certainly is at our place. We have to help that investigator, give them tools to make them more effective at doing the science. There's a lot of IT tools that have to go on. Now, while we're doing that, we have to bear in mind that 5 years from now, this is my rough projection, is that the clinical systems we use today, the EMR and the provider order entry, will begin to be materially affected by the types of genetic work. The decision support will change. That the databases we have underneath will not only have phenotypic data, but increasingly genomic and proteomic data. And that we'll have to accommodate this. And so we ought to use the pursuit of the investigator as a way of learning about the future of the clinical systems that we have. How will they have to be different? And I don't think we fully understand that. So we start here with the researcher, and we have a couple of things here. We'll just go ahead and put these guys all up. So this is, you order your tests. You know, you're looking at asthma. One of our big set of investigators is looking at asthma. A number are looking at Huntington's disease and hypertension. And you want to run a microarray, or you want to do some examination of the genetic or proteomic information here. We have laboratory information management systems that run the tests that you'd like to have, and we store this thing in an integrated genomics data repository and research patient data registry. We store that, and we store phenotypic data that you might have gotten from our systems, along with experimental variables that you would have collected in addition to the normal patient care data, along with assay results that came out of this work here. Similarly, we subject them to a series of discovery algorithms. I mean, algorithms designed to help you interpret correlations, and we'll show you some examples of that in a little bit longer, but help you to sort of understand the relationship between the genetic data you're seeing and the protein data that you're seeing and the illness of the patient. An interesting conversation, I mentioned this to a couple of folks at lunch. Part of our people believe that hypertension is not actually a disease, that it's a symptom of at least 15, and no more so than fever is a disease. And that one of the reasons you can infer that is if there is a phenomenal amount of genetic diversity, which it seems to sort of be related to hypertension. Perhaps there's more than one path to hypertension lying behind all of this stuff. And this is the type of science to help learn that kind of stuff. So this also started here with us is to create this clinical decision support system which has a genomic proteomic basis. Now, let's just to round out the arrows here. We need from here, and this is not well understood at all, is the data model. How do you represent the genome? Do you represent all of the genome? Do you represent exceptions to it? You can make arguments for both. If you represent all of it, then you're in a position later on as the science improves to come back and do further work. If you represent all of it, it's a phenomenal amount of storage. So how do you code it, structure it, and things like that? How do you measure or store information about protein sequence? And you can wind up with strings of data that have 5,000, 10,000 variables long. So we have to learn about how to structure this stuff, both its raw form, its sort of filtered form, along with annotations that the investigator or the doctor will make. Similarly, these algorithms become classification algorithms. Now, what's interesting to me is if I look at a lot of the decision support that sits behind our systems today, we got a lot. You'll see that in the slide. We got a lot. It's very Boolean. If this, then we got a problem. You know, so if drug A and drug B combinations, you know, highly problematic, black box warning in the PDR, do something. If we look at this in fact appears that you take a very long string of data, very little of it's phenotypic, very large amount may be genomic and proteomic, and you pass it across a very large database of analogous specimens. And you look for fit. To what degree, if I think Dominic has cancer, and I run this very long string across the database, is his cancer like other cancers that I have seen? And to what degree were the treatments in those cases where there's fit, you know, led to good outcomes? Interesting question. What does fit mean? And particularly when you have, those of you who took statistics know that the number of variables can't exceed the number of cases or statistics fall apart. Here you have examples where the number of variables may dwarf the number of cases, and so the math is a little rough or poorly understood about how to do this. Second, this database of large like may not all be human. In fact, we may be comparing Dominic to mice because, in fact, the animal model is a reasonable analog to what we're looking for in this stuff. But we don't know that. And so part of the discussion is, what does this look like if we're going to try to determine disease A from D, both of which cause hypertension, or one form of breast cancer from another form of breast cancer? So assuming we can do this, and this hasn't been done, you're now sitting at provider order entry. You order a diagnostic test. We run it through the lab for molecular medicine, which does all these stuff. The assay results go through this algorithm. The results are stored, and the interpretation comes back to the old clinical data repository and says, here's the deal. Dominic's got Form Z, or whatever has to happen, and plus here's some test order guidance here. So this is a phenomenally important investigative stuff, but it also will be quite important for, the treatment of disease. One of the things that's interesting, and our researchers have this as part of their strategic plan, and I mean, this may have it for all I know. Their goal, and it's not just theirs, it's the world goal, is that no one dies from disease by the end of the century. You know, you can still get run over by a bus, and that's a sure way out of this world. The other is your body will fall apart, and that may not be preventable in a long sense, but all diseases ought to be able to be kept at bay. You think about that, I said, what a remarkable societal accomplishment after thousands. You still have to treat them because it's not gone. We may not see it. My kids, I hope, see it, and my grandkids. So there may be something as profound on the practice of medicine as what that implies. What this requires is that you create these tools to support the investigator. So you will allow them to correlate genomic and phenotypic data. You will allow them to keep their own research data private because this is a big deal for a lot of these folks. On the other hand, you allow them to publish it for external access with other investigators and to do a series of things that are really quite related to understanding the genome and the way that it expresses itself, maintaining a population of folks. Here's just a brief example here, one here. If you have post-traumatic stress disorder, in a lot of ways you can get that. Some percentage of patients come out with major clinical depressions following that. Why is that? Why those some and not others? It turns out that, in fact, in one of the ways, this is sort of this IGDR-PDR, you can actually take a look at and understand that this is the ICD-9 for major depressive disorder. We see some Prozac, and we see post-traumatic stress disorder was caused it, and we see this particular set of alleles as part of the patient here. So the beginning to understand that there, in fact, may be a genetic basis behind why some get it and some don't. It doesn't tell you how it happens, but it starts you down the path of this discovery. One thing that is impressive to me about this particular realm, and look at all these things, is the amount of unknown computer science here. I mean, it's kind of, we have a grant here called I2B2. It's short for Informatics for Integrating Biology in the Bedside. It's one of 4 National Institutes of Health in the States, National Centers for Biomedical Computing. It's surrounding the creation of tools here. And this is the high level, suitable for board presentation, but they don't get it either, of what is being attempted to be done here. So, to give you an example, if you were doing studies on asthma, one of the things we know about asthma is there's about 10% of asthmatics do not respond to traditional steroid therapy, wind up in the emergency room in the hospitals. Why is that? It appears to be a polygenic disorder. But we also want to know whether you smoke. Is smoking a coded term in our records? Not a chance. So we have to do natural language processing to excise the term. We have people working on feature extractions from images, so you can retrieve an image. Say, of the bazillions of things that are being produced, I'd like the MRIs that show the following. Similarly, one has to take very long pieces of data which change over time, have lousy statistics, and do them. So this has a very intense computer science approach to it and set of activities. So people from MIT and from Harvard, from Boston University, along with our own folks going after this particular range. Next one here. So that's sort of genomics and a different sort of orientation to the theme here. Now, this one is one of these things that just cause you to get gray hair to the degree that I possess anymore. About 2 years ago, we asked one of our folks, who are actually folks who's Bob Greenis, runs the Decision Systems Group at Brigham and Women's Hospital. Bob, here's the question. Put out a lot of these clinical systems. A lot of EMR use, a lot of CPO use, and we want to know how many instances of medical knowledge exist in these systems. And you say, well, what's an instance of medical knowledge? Well, a drug-drug interaction rule, one instance. A reminder to follow up if you haven't seen the hypertensive male in 6 months, another instance. Post-operative order set, another instance of medical knowledge. How many instances of medical knowledge? Bob came back and said, here's the deal. 23,000 instances of medical knowledge exist at that time across your system. You may not be able to read this in the back, but here's a bunch that are related to medications. Ranging from chemotherapeutic to stuff that's specific to kids. There's a variety of stuff here, and I'm getting old enough I can't see this far away, but I can't leave that either. So, but anyway, I'm stuck. Stuff related to drug lab interaction or adverse drug event notifications where post facto you discover something here. Stuff related to how you present results. You go all the way down the line here. So there was this phenomenal amount of knowledge then. And then the next question is, well, how well do we manage it? Clue number one, we didn't know what the count was. So that's a clue that you don't manage it very well if you don't know how well do you manage your staff? Terrific. How many do you have? I don't know. So green, which I think is this, I'm colorblind too. I'll tell you one story, and I won't make this very long. I have been going out with my wife for 30 years now. And so, she was 18, I was 19 when I met her. This is back at Duke. We were undergraduates at Duke. And I thought, and I was going to impress her by what a smooth cosmopolitan guy I was. Because a babe like her, she'd be wanting to go out with a smooth cosmopolitan kind of guy, you know what I'm saying? So I went out and said, I'm going to go buy a suit by myself. I've never done this before. You know, Dad had taken me, Mom had taken me. I went out and bought a suit by myself. I came back, and there she is. And she's trying to woo me, so she's trying to be really nice about this whole thing. I said, look at this suit. She's saying, when do you think you'll wear that suit? Clue number one. Clue number one. I didn't get it at the time. I got it after the fact. So it's a good-looking brown suit. A fella could wear this all kinds of occasions. She said, well, I don't know how to tell you this. It's actually bright green. So unless only at St. Patrick's Day parade, but other than that, I'm not sure I'd wear it. So I have been bad on colors. And you can see the result. Look what I have, all right? Blue pinstripe suit, wingtips, white shirt, red power tie. Do not leave the formula. Anytime you leave the formula, you're just asking for trouble here. So it causes trouble. Actually, you know what causes trouble? Slides like this, and you guys who put your stop signs parallel to the ground goof up the positional orientation of red at the top and green at the bottom. It throws. I actually have to have a passenger when I drive. We were in Banff, Jasper a couple of years ago, and my wife and I have to say, we're coming to an intersection saying, what do I do? There's nothing like that calm in the car where the guy doesn't have, the driver doesn't have a clue whether it's red or green. Anyway, this color means that in fact, we have looked at it recently. Somebody's reviewed the knowledge. There's been a refresh of it. This color means since it was authored, nobody has looked at it. I mean, nobody. And so 5 years, 2 years, whatever, not you. This color means it's sort of partial and mixed. So one is we're lousy at actually managing them, keeping them current. Second, to what degree is it consistent across all the partner sites? So if you have a series of rules about diabetes care, is it the same at the Brigham, the Mass General, the Faulkner, and all the way down the line? And it's obviously highly inconsistent. So big for us is to manage this, and manage it for a couple of reasons. One is if you have systems working on logic that is now wrong, you're asking for trouble and hasn't been updated in recent times. You're compounding heterogeneity of care and unevenness of care if you tolerate, diabetes rules going on across the board that aren't the same. Similarly, whatever we think this count is now, what do we think it will be when we start adding genetic guidance, et cetera? It's going to go through the roof at a level here. So getting our hands on this knowledge and managing it, because this is a scary thing. So we have a group now, 9 people, been created to manage, led by Tanya Hongsmeyer, who's a physician out of Cerner, that has committees who vet new knowledge. They have some tools for knowledge collaborative sharing. So endocrinologists working on diabetes rules, or oncologists working on some chemotherapy rules. Very early forms of this repository where you can store it, you can retrieve it. You both, human readable form and machine readable form. Ways of editing it and getting it into applications, and then looking at how well it's followed. Sometimes it's not well followed, and maybe because we didn't get the rule right, maybe we didn't understand a variety of things, et cetera. This is an example, early form here, and this is a way of just retrieving. So you say, I'd like to understand what instances of medical knowledge do we have in, surrounding emergency medicine, cardiology. You can read this as well as I. And I might even want to filter it by what applications does it show up, whether I'm talking about young people or old people, and whether there is a particular organization here. And you get something that looks like this. It says, we have the following rules. This is the nature of it. This is the extent of it. And if you actually want to go see the logic, sort of the human readable form of the logic, this is what we have here. Very early forms of getting our hands on this knowledge. Now, I actually don't think we'll be able to handle 23,000. But nonetheless, you can go after high leverage areas, chemotherapeutic stuff because it's dangerous, diabetes because it's prevalent and inconsistent, et cetera. Now, this last set of slides, and then we'll stop and see whether this was coherent at all, or may have spurred other questions here. This is an area where sort of bring a number of themes together. This is a SMART form. LMR is our acronym for the Longitudinal Medical Record. And so that's just, it means an EMR, is what we call it here. Now, what's being put together, early forms of this exist, is where the system alters what it presents based on the system's knowledge of the patient and the system's knowledge of what ought to be done, both what the partners as a whole has decided ought to be done and perhaps what you have decided ought to be done. So in this case, we're looking at a patient who's diabetic. And it says, well, I know to present the hemoglobin A1C and show you the goal, how well this patient is doing relative to our goal. I know that there are certain sets of health maintenance reminders that are necessary here as part of the routine provision of care surrounding someone who is diabetic, and need not be purely diabetes. I mean, to the degree that you're a woman of 50 years old and you haven't had a mammogram, we ought to do that too. That I know that there's a series of medications that are likely to be ordered. Here is I'm going to go ahead and populate the complaints here, and I'm going to go ahead and show you the active medications here too. And along this line, to the degree that I think this is necessary, and I find no evidence of the following patient education has been delivered, I'm going to suggest that. So it is actually altering the form of the record based on what we know about the patient, along with some tabs over here that allow you to go to a variety of places. The reason for doing this is twofold. One is to make the doc's life easier, so that you get to this one screen and it's quite quick in theory, although it remains to be so far it looks fine. It's quick to get this stuff done. All the relevant stuff is there. You're quickly through this stuff because there's no time, and away you go. The second is to guide the practice. This is a form of knowledge. This is a form of knowledge that says when you're treating, this is the following set of data that ought to be important and ought to be considered as we go through this. Now, behind this is this other conversation which is underway, which goes back to the genomics. So if you say, all right, John, I've taken a step up in intelligence of the electronic medical record, and this represents, the step following is this. And that is to look at, and we started the examination of the structure of the database underneath it. I mean, what do you store? And we have people who are all over the map. Some people who think you store everything. We have other physicians who think it's all a pile of crap. It's a single test. You run the test, you get the report back, case closed, no need to store other stuff. I don't really know. We'll find out. And then the other is to start to get a handle on these classification algorithms. And so we'll do some algorithms, largely in asthma care, to start some algorithms based on can we do a reasonable job of telling sort of the different types of genomic bases for asthmatics and understanding whether you, for a very practical example, will you respond or not respond to steroid therapy. It's important to know that up front, because if we don't know that, we learn the hard way and all of this stuff. So a couple things here, and this is more on the research stuff here. I think, and it's particularly important for us, and it can be important in other IT groups where you have a sort of an academic background in these settings. We do a fair amount of research, IT applied research. It has to have some very sort of goals. One is that it ought to have a reasonable prospect of leading to something implementable within 3 years. We don't have to implement it, but it ought to be a reasonable prospect. So I'm not all that excited now about stuff that's 10 years out. So it had better be very applied and have sort of short-term, near-term utility to it. What I do is in my budget, I reserve approximately $7 million a year for the purposes of IT research. It's about 7% of my budget. I have a very large budget to go off and do this stuff. And one of the ways that we spend it is examples here. If you're an IS employee, or you're an employee in biomedical engineering, or you're one of the informatics groups that we have around here, you can submit a request to tap into what the research council say, I need some money. Not to exceed, $50K, and generally they're a lot smaller than that kind of amount. But I have a research project that I'd like to do, and I'd like to request it. So you have to send, what's the deal? Why is this important? What are you going to do? Why is this a good way to do it? And if you had a reasonable answer, why are we better off as a result of that? We've funded 42 projects. These are examples here. These kinds of projects to go off. And part of these, if you go back to the themes, are sort of leveraging of themes. And so we have projects to extract features from images. We have projects, for example, I thought it won the Cool Project of the Year award. We actually, through a camera here, you cast on a surgical gown or field the keyboard, and you move your hands. And in fact, you're using the keyboard and sort of getting rid of this nonsense of a keyboard where you need at least. Turns out it doesn't work very well. Well, there you go. We learned something. It was kind of cool anyway to go off and do this kind of stuff. So to have this kind of stuff where these projects do things, modest dollars, sometimes they want programmer resource. They don't want any money. They just want a web developer from the web development group for a quarter of the time for 3 months. That's what they want, to try some stuff out. So we have, these are a set of them, and some of them, this turns out to not work very well. I mean, people don't know their family history whether you ask them electronically or in paper. They don't know. So the fact that we're doing electronically isn't very helpful here. Well, that's, there we go. We understand some stuff here. Some of these are quite impressive, and that is to realize that if you look at black box warnings in the PDR, if you know what they are, and the physician's desk reference are black box warnings, which mean this is a very serious interaction. You had better pay attention to this one. And it's to find that, in fact, we don't have a lot of these in our systems, and they're often ignored, which is a very important consequence here. So we have a research agenda across all of these themes to help us understand a little bit more about what's coming down. And the staff love it. This is a big morale kick to go on here. In addition to that, we also go outside. So I've mentioned before the National Institutes of Health funded 4 national centers for biomedical computing to do the sort of next generation of IT and research. One went to Stanford, one went to UCLA, and 2 came to Partners. And so we have gone out, and these are $20 million each, and have done this. And then through Boston University is the Army, U.S. Army looks at, wants to re-enlist soldiers. It's very expensive to have a soldier train and then leave and have to replace them. The main reason soldiers leave is because the family hates it. The family doesn't like the life. So a series of trials to introduce stuff into the home, whether you're the woman left behind or the man left behind, is to sort of improve the social well-being, the connectedness. And actually the first examination will be pregnant women who are either first kid or young kids who feel phenomenally isolated as a result of all this stuff, and to give trials there. And then HR, Agency for Health Research and Quality, I've done some stuff here. And then we actually have some work from the eHealth Initiative. So for us, the research is very important to keep, if you believe that the theme matters and that these are good areas to develop competency and prowess, because whether it's patient safety or imaging or whatever it is, it's going to be very, very important over many, many years to be very good at this, because we'll find projects, some of which we understand today, some of which we'll understand later. But if you believe that's the case, then you have to keep these people on the edge. I mean, they have to be pushing the envelope and learning so they can see where things are going. To variable degrees, but they have to do that. So a research arm, whether internally funded or externally driven, if you look at the total of this, and Partners IS does one of the national centers, the Brigham Radiology does the other. But this represents, if you just take one of these centers out, this is $28 million in revenue brought in, grant revenue last year, and another $20 million in industrial partnerships over the last 20 years, which is really big numbers to have brought in, but nonetheless highly important to leverage this aspect of it. So that sort of rounds the equation on this kind of stuff, is the creation of a research component. If you look at the top 20 people in Partners IS, so the CIO of the Brigham, big deal job. CIO of the Dana-Farber Cancer Institute, another big deal job. Person who runs all the networks, that's a really big deal job. But 4 of the top 20 people are physicians, and they actually run R&D groups, and have various flavors that go off there. Another 3 of our staff, of the remaining 16, are actually nurses by training who wound up in various IT roles. So I'm going to, last pithy comment here, and maybe it presumes there were pithy comments leading up to this. We are, as you look at our strategy, in applying IT, just as presumably you all are doing or aspire to do, part of our strategy is notion of themes. And the theme is the sort of creation of core critical competency in areas that will matter to us. And they have the following 4. And that we have established these 9, which have been relatively static as 9 areas for 5 years now. And I suspect will be relatively static, although the composition of them, again, may change. So I am done with the prepared comments and some unprepared comments that came in along the way that I couldn't stop. And let me see if you have any questions.
So any comments and questions? And what we'll try to do is get the microphone to you so we can hear you and record your questions or comments. Who's going to start it? It's a quiet group. Over here.
About halfway through your presentation, you had a nice slide on your failures to do with the way you were dealing with patients and the fact that they weren't, there wasn't follow-up on one example. I'd like to know how you gathered that data and how do you know that you didn't fail in gathering it in the sense of how accurate do you feel it is, and how did you, I mean, some of it was fairly easy to gather, but some of it didn't look easy to gather at all.
Well, I think, Don, you can be the judge, because you may not have seen that on the slide, but where these are published. So these wind up in the peer review process. We have a group of folks who are health services researchers by training. They're run by a guy named David Bates, who does a lot of this work. And we supplement, we cover 9 people in the group. They have to go out and get grant funding, but their academic careers are based on doing this kind of work. So you rely at a level on health services researchers presenting their work in peer-reviewed processes, and and that the peer review process says whether it's well done or not well done. It's from a scientific perspective, whether it's good health services research. So that is part of what we insist upon, is that we'll keep you afloat should the normal ebb and flow of grants ever ebb. But nonetheless, that has to be, this is what you have to be going after full professor, and you have to be subjecting this stuff to peer review. And if it survives that, we'll act on it. So I think the numbers are, reasonably good. I'm sure that, like a lot of the stuff, you'll get conflicting data on other stuff. What's interesting to me is when we try interventions, how uneven the IT response can be. Sometimes it's a phenomenal gain. Sometimes it's really disappointing. Golly, how come it's not working? And that becomes actually the second iteration of evaluation of why didn't anything change or not change as dramatically as we thought. I think, frankly, it's a phenomenally alarming picture. I mean, to have that level of stuff go on in a place that's got some really great doctors and some really great patients. I'll give you an example. We say, well, how does that marginally abnormal happen? The average doc at the Brigham, average primary care provider at the Brigham gets 240 test results a day. You got to be kidding me. Now, I get about 150 emails a day. I delete every other one, just as my approach. And the rest, I forward to the remaining 20 people. Would you please follow up? Thank you. I always put thank you, really courteous and all that other stuff. But 5 minutes later, I'm done, man. This is all moved along here. But you're not doing that with, you got to read them, they fall through the cracks, and you're tired and all this other stuff. That's how it happens. So a lot of this happens.
Questions?
You're introducing a lot of change, and one of the things I'd like you to comment on is how do you look at the changes that you put in place and determine whether they've been successful or not? As an academic center, you attract a certain kind of physician, a certain kind of clinician, and then can you comment on whether those same criteria would be useful in non-academic centers?
Yeah, I think it's introducing changes is hard, you know that, and I think that you have to be conscious of culture when you go in, because the words you use are different and the why is different. So I can go into the Mass General and the Brigham and say, we're going to do some stuff and it's research. Cool, we do research. Cool. You go into a community hospital, they have no interest in this whatsoever. In fact, you just killed it if they think you're going to experiment on them, on things like that. So it has to do with language. It has to do with understanding context. There are times when we don't introduce a change because the context isn't right. They have to evolve to a point where it's like teenage kids, evolve to a point where they're receptive. It involves astute political reconnaissance that goes on across the board. So I think there are aspects that doesn't matter what you're changing, whether it's an academic department of medicine or 2 docs who are primary care providers and business people. At the end of the day, some of the fundamentals of political reconnaissance and timing and language matter a lot. But at the end of the day, it boils down to a discussion. And the discussion says, we think we have an issue. We do want to talk to you about that. We think we have some stuff that may be helpful. We want to talk about that. I'm not here to sell this stuff if it's no good. And I'm not here to foist this stuff on you because that's deadly. But I do think it can be helpful, and we ought to talk about that. And I remember, in a lot of the community docs where they have to pay for the electronic record, the answer is, John, I believe this, man. I think this is the way the world is going. I'm supportive of this, et cetera. But I can't afford $10,000 a year. I can't do it. And I said, you're right. I'm not about to dump this thing on you because it's deadly. So I have to go back and figure out ways to drop the cost of this thing. And so if there's a sort of honest discussion, which is based on me being candid about what will work and whatnot, that's very, very helpful. It still takes a long time. There's a wide range of human beings. I think there's 5% of any community that will adopt it if the electrons are moving. They just love this stuff. There's 5% who hate this crap and they'll die or retire before they let you get to them. In fact, we've got a list on the board, the ones that we think will check out in the next 5 years. But shoot, that leaves 90%, half of whom roughly just need a good case to do it, the other half who are really hard. to get through because they really want the demonstrated value, they want all the risk done, et cetera, et cetera. I'm not giving you a good answer other than I think it takes phenomenal skill. There's some stuff that's consistent across the board, and at the end of the day, it had better be an honest discussion, and you better have a track record going in there, and it better ought to look like it's a two-way meeting of the minds here.
I just want to inform the people coming in via the web that they're more than welcome to ask a question to the speaker. So send them on in. We're live here, and we can see your questions if you send them. So.
Other questions? Well, John, I talked to you before and mentioned that I think it's extraordinarily rare, even in academic medical centers in this country, to have the degree of focus on IT and its importance. So that's one issue, I think, that hasn't really fully penetrated the Canadian hospital. The second aspect is the degree to which you have an autonomy or I guess I'll call it a business envelope within the institution that you can allocate $7 million to research, and other resources. And it seems to me that one of the things I'd like to see come out of this is some guidance. Like, how do we create institutions that are open to this level of recognition of the importance of IT and the role it plays? And what do we need to create in terms of our CIOs or whoever they're going to be, that they're literally trusted to be this type of leadership? I don't know if you can comment broadly on that.
Yeah, I think, as you all can tell, I believe that the research part is terribly important because I think that's how you get a read on whether the world's going left or right or something in between. So in addition to the strategic value, it is a phenomenal draw of great talent. I mean, you get some really smart, exceptionally competent people because this is tough. I mean, this is hot shit. I mean, to coin a technical term. So, I mean, no, I'm serious. Whoa, this is cool. And so you get some extraordinary talent, and even a lot of the people who are doing regular jobs, help desk or whatever, to be working in an organization that's doing this cool stuff, there's pride. I mean, there's just great pride and all that stuff. So it has a great talent attractor, et cetera. So there's a bunch of value to going on there. I think, Dominic, I guess I think a couple of variables have to line up. One is to have an organization that's receptive to it, the idea. And maybe it has limits on its receptiveness. So there may be dollar limits or nature of it, et cetera. And it can be receptive because it's academic. It can be receptive. I was telling you at lunch that I think Humana has a very big HMO in the States. It's a very large IT innovation startup because that's just who they are, how they think about themselves. So there's receptivity. The second is that I think that it's quite important that the person who has sort of the analogous job as mine really like this stuff, is interested in it, because you have to sell it. I mean, a lot of what people like me do is they sell ideas, and they persuade trustees, and they persuade the leadership to make investments, and you better feel that passion coming out and being articulate. So you have to believe personally that. Now, let's presume you've got that. You've got a receptive place. You've got someone who's pretty good at selling it. I think there's a couple of ways to do that. One is to take relatively small dollars, and small dollars can be relative. Now, I told you about those 42 projects, et cetera. I think if you came out with a number that was 30,000 or 40,000, that may still be large. You can actually get some interesting work done with a relatively small amount of money. It's amazing to me how small dollars and sort of organizational legitimacy that, you're a person in the middle of the organization, we're giving you 10 grand, a programmer for 2 weeks, and we're going to put your picture in the newsletter. And you get that person will work their fanny off. It's, in terms of the hourly rate, it's scary. We got to be sent to jail for some form of indentured, servitude for this. But you get a lot of mileage out of small dollars. What I don't know is to the degree, because I now understand it in the States, is the grant obtaining opportunity, whether it's through governmental dollars or philanthropic dollars or times industrial partnership dollars. But I think you start that kind of scan. This thing of this magnitude that you see with a lot of money going on is essentially 16 years in the making. So it took some time to get this. I remember we hired our first medical informatics guy, a guy named Jonathan Teich, who designed a lot of the Brigham CPOE stuff. Man, the conversation I had about one FT was unbelievable. Well, because he's expensive. He's a doc. They always are. But the other part of it was, what's this role and what will it grow? So I think there's a ramp up that can take some time on this thing, because it's a hard shift, an unusual shift for some organizations to do. But nonetheless, I think it's quite important for the field in general, and to some of David's opening comments about all this.
Questions or comments? I'll make sure to.
Yeah, after hearing your talk, I had the impression that if you follow the theme strategy for IT, that you would have to develop your own like competency or core competency within your team. Is that the right impression, or is it possible to also use themes as part of your IT strategy, but then relying on outside sources, perhaps from vendors?
I think they don't have to be yours, your staff, to do the theme stuff, but you have to have access to that talent. And you have to have access to the talent that you think, one is high quality, but the other is engaging in their own research stuff. So you're right, I say, golly, I'm not in a position to write my own electronic medical record. What are you, nuts? But I'm going to partner with a vendor who is going to do that, who I think has got the competency, the talent, the track record, and is looking down the future, and that's how I'm going to have access to that talent. It does force you to go through and say, well, what talent where does it really matter that I have? You know, what you didn't see up here is a theme called, we want to have the best general financial systems in the world. You know, we really want to cut that payroll like nobody else can. And man, that general ledger closing ought to be in subsectors. Well, I don't want to screw it up, but I'm quite willing to be mediocre or average in certain areas there. So, you know, it forces you to decide what. But to your point, you don't have to possess it all.
Other comments? I want to put a question, John. John, to the degree to which you feel comfortable speaking about it, you've had the experience now for a couple of years of working with a group in Alberta. Mm-hmm. What have you seen there that interests you? What do you see are the areas? Alberta, as you're aware, has kind of led the country in introducing electronic health record. Can you comment on that? Are there lessons there for the rest of us? Have you seen good things?
Oh, I think it's been, I have seen good things and see some very talented, dedicated people. I mean, it's neat, and it's the kind of thing you'd always want to see in a mission-driven class of organizations that, you know, got that level of skill and talent going on there. I think there are parts of what's going on there that you could be in Boston, you'd see nothing different. Change is hard. Getting people's priorities, making choices on limited resources is a political contest, which is always very exciting. You know, sometimes the technology is really difficult to wrestle with. So there's aspects of it which are almost universal. What's striking to me is the difference that the economic structure of the healthcare industry makes. I mean, I'll give you some examples, and I'm just what the hell do I know? But to have the provincial leadership, essentially out of every 4 years, you get 2 good ones. The first year they don't know what they're doing, then they're good for the second, third, assuming they're good, and then the fourth they're worrying about coming back. So you got 50% of your time, you've got some chance of getting this kind of stuff. That's different than we have because it's really not governmental driven. It's more driven by CEOs and places like that. So we don't have that sort of odd cycle. The second is that by law, anti-fraud law in Medicare, if you're a doc out in the community and I want you to have an electronic medical record, I can't give it to you. You have to pay for it. If I start covering it, paying for it, then it looks like I'm inducing referrals, and I go to jail as a result of that. So we 7,000 docs, 3,000 are in the community, 4,000 are employed, so we can cover that. We're not going to go to jail there, but the other 3,000, we have to sweet talk. And there's phenomenally losing economic proposition. So there's just a different ability and a different pace that will go on. The other is that record locator, really fancy, that we're going to connect everything. What's the economic value of that? Don't know. And in fact, there may be no fiscal upside to that particular activity. We make no more revenue by being conscious of your drugs from the BID than if it doesn't matter. And in fact, we might be costing revenue. To the degree we don't repeat stuff, don't get paid. What's the deal with this? We had to run some more radiology tests because they're sort of margin makers at this point. So there's no revenue upside. There's possibly a revenue downside. So John, what are you doing? Well, it's for the greater good of the population of Boston. I'm happy for them, man, but you got to stop it because you're killing us, draining all the money we work so hard to get. So we have to sort through that sort of economic proposition, but that sort of economic disincentive doesn't appear to be the same kind of stuff that is at play. You can affect regional stuff with a different degree of authority. Now, maybe you living here say, I don't know what country you're from, buddy, but that's not what's going on here. But nonetheless, you do have a provincial role that can cause things to occur. It ain't the UK where the NHS is coming through, like a big gorilla to do a bunch of stuff, but nonetheless, there's a greater ability in this country to affect regional strategies because it can make up for economic differences and it can act as the force that binds. Now, that doesn't mean it's easy, because I see it's not easy out there, and I know that it's not easy out here. But it's a much more potent ability than what I see in the States. I do think one of the things we see in the States, and this could be based on great ignorance of what's going on here, the IT innovation level is higher in the States. The fact that this kind of stuff goes on, and there aren't a whole lot of places that do this, but there's a good half dozen in the States that do that. I just think there's more of it for whatever set of reasons. And maybe it's because the NIH exists and has a lot of money that does this kind of stuff, or HRQ does this. I don't really know. But that would be the sense, is that there's more of that coming out of there. But
Other comments or questions from anyone? I'll make sure I don't lose anybody here. If not, I'll make just a few remarks myself. Oh, sorry. See that there.
A couple months ago, there was privacy legislation regarding IT that's come in through for Ontario. You guys have had HIPAA for a little while. Has that given you any difficulties in gathering some of your data and some of the approaches that you used in taking the data and manipulating it?
Yes and no. The no part has been relatively straightforward. Is when you come to one of our places, we give you a notice that says we will, in order to treat you, we will seek and obtain data from other providers. Just to let you know, we're going to, whether it's within partners, one of our 10 hospitals or outside, we're notifying you. The legal distinction, we're not asking your permission. We're notifying you that we're going to do this. We have to sign indicating you've received the notice, but we're not negotiating this conversation. So that's one way to deal with it, and maybe that can't be done by law here, but you can do it in the States. So that's a minor change. The second, there's actually been very little prosecution of it in the States, and that which has gone on, they ought to have been shot anyway. These are people, you may have seen there's a release of HIV information in Florida last week. Those people, wherever they find them, will get shot. Actually, when I remember I'm submitting my HIPAA capital budget, when this was first coming, I had a capital line item called a guillotine. And they said, what's the guillotine for? I said, HIPAA violators. We're going to take them out and lop their head off here. One hot tip to all of you have to deal with CFOs, and I deal with a capital budget. We're going to another capital budget cycle. You got to come in. His CFO wants to go through your budget, okay? That's part of his or her job, and they got to come out of that discussion having taken something off the budget, okay? Otherwise, they don't feel good like they did their job. They actually don't know what they're looking at, so they want to take something off, but they're hesitant to mess it up, by taking off all the servers. That would not be a good idea. So you always put something in the capital budget that they can, one, they'll recognize, and second, can take off, okay? They feel good, and usually a big item. Or a ludicrous item. So I put the guillotine. What the hell is this for? Oh, it's yes, I didn't really want to do that. You got to be kidding me. Second, he feels better. Now, a couple of years ago, just to really goof him, a guy named Peter Markell was a wonderful CFO. I really worked well with him. I put the Partners satellite, $2 billion. What the hell is this? It's Partners satellite. What the hell do we need that for? Beam stuff up and down. You know what I'm saying? Beam stuff up and down. What kind of stuff? Stuff like radiology. Beam up, beam down. Got our logo on it. Get it out of here. Whack. Hey, man, what do I care? I didn't want the stupid satellite anyway. And he felt great. Oh, I whacked his budget. It was $1 billion. Now look, it's only $70 million. Oh, a lot of progress. Way to go, Peter. So anyway, there has been not much that kind of stuff. Where it has gotten more complicated is in the research realm, where we have to obtain a different set of, so if we do a selection, we have this way that you can anonymously select, go into this database and say, tell me how many white males, Armenian descent, with these diagnoses, taking these medications we've treated in the last year. And it says, all right, it comes back and says 412. And you say, hey, that's terrific. That's enough to do my clinical research, is 412. I need to now reconsent them and to obtain for research purposes, et cetera. So any reuse of, even if we have your specimen a piece of tissue from you, and it was obtained for one research purpose, and we want to use it for another one because we preserve it. We have to go back and ask permission to do this kind of stuff. So that's where it's been the biggest hassle, is in the research realm of having to reconsent, often over periods of time, for use of old data or use of old tissue. And actually, in some cases, I think there's likely to be change in federal law because it's too restrictive. So again, I don't know the specifics of the law here to know whether it's analogous or more severe or whatever. Could be. No, and my general conversation is when we had a discussion with the research leadership a couple of weeks ago, and there's the attorneys and the corporate compliance people saying, the law says this, bam, bam, bam. And there's this really dour opinion here. And the only thing I remind people of is attorneys are like consultants. They are there to give you an opinion, to phrase a risk curve. You then make decisions of where you want to sit on the risk curve. And you can decide to accept some risk because you think that it's operationally ineffective or constraining. And it becomes a judgment call. You can go too far out and get in a lot of trouble. You can be too close to the law and hurt yourself, frankly, and not actually benefit the patient at all. So you'll have to make your individual judgments along those lines.
John, thank you very much.
Pleasure.
Again.
Thank you all.
I
Hope this
wanted
is
to,
interesting.
just before you applaud, say a couple things. First of all, you were here only a month and a half ago, and can't tell you how much we appreciate your coming back and being willing to be with us again. Both times have been incredibly informative, and as you know, you've been at many things that we've had in the past in other places, and it's always a good information and a good show. I do want to comment, though, about your colorblindness. That's not the only reason that you have dressing problems. I remember a story from you one time where you went into a major meeting when you were working with ADL, and you ended up at the meeting with your blue jeans instead of your suit. Yeah. And it doesn't just extend to colors. So.
Yeah. Actually, if you have time, I'll just tell you two quick stories. I'm really bad at, I'm lucky I got my, things on. These are more recent than the dumb. I play racquetball 3 times a week. So alarm goes off at 5, put on my jeans, my shirt, and I'm desk down to the courts, play my game and get out and get dressed after that. A couple of months ago, I got out and I had the game's done at 7:30. I have 8:30 an IS retreat, room full of IS people. I'm supposed to be the big deal, kick it off, say all the flowery words, get them under some real work. So I'm ready to go off and do that and open up my damn locker, and I have everything but a white shirt. I don't have a damn white shirt. Where am I going to buy a white shirt at 7:30 in the morning? Nobody sells white shirts at 7:30 in the morning, so what am I going to do here? Well, I can't wear the sweaty T-shirt. That's not going to cut it, okay? So I went upstairs to Lost and Found. So you got any old white shirts? I don't have any white shirts, for God's sakes. Not in a locker room, for God. They have this T-shirt here that this lady held out as far away she could. The odor was unreal, but it was dry. I'll take it. It's dry. I can go with dry. I then went to the Sheraton Hotel, which is right next to where we hold this meeting, and I went up to the bellman, and I said, buddy, I want to buy your shirt. This look, I said, what? White shirt, the brown, gold lapels. I said, I want to buy your shirt. Here's the deal. I'm stuck. I got to buy your shirt. And he looked at me and said, how much? I said, $20. I could buy your shirt. He said, I don't think I have your size. That's not my issue right now, is the size, okay? So I bought the shirt off his back. He went back in the locker room, stole somebody else's shirt that goes on here. So that's story number 1. Story number 2, same deal. Got down, opened up the locker. Damn, I got a brown shoe and a black shoe. Worse than that, both are left feet. Why does this happen to me? And I won all the games. I was feeling like I'm on a roll, but no. So I said, well, what am I going to do here? I can't wear the white racquetball shoes. That'll be too obvious. And the second, I can wear socks, but I got the socks with sort of the gold toes. If you get men's boring black socks with gold toes, well, that'll be, that's a giveaway. Nobody walks out with shoes with gold toes. I'll wear the shoes. No one will notice. Well, let me give you a hot tip here. People notice in short order that not only are they different color, but they're both left feet, okay? It takes 5 seconds. What are you doing? And in fact, what was the movie, Best in Show or something like that, where anyway, those remember the dog. So I said, that's okay, I'm cool, I'm a guy, I'll ride through the whole day like this, okay? By noon, my right foot was dying, absolutely dying, because it was being bent in ways that your right foot is not supposed to be bent in. So, but I got through the whole day. And a couple days later, I was telling this story to a room full of department heads, and one woman raised her hand and said, our office is on the 11th floor of this, office tower. Right below is this big mall. There's, a lot of shops. Why didn't you go downstairs and buy some shoes? It had never occurred to me to go buy some shoes. And it's reminded me that and I believe that there are differences between men and women. I actually think women are superior to men, but nonetheless there are differences. a woman would have perhaps, and this may be, if I overgeneralize, excuse me, buying new shoes is not the lowest hurdle rate in the world. I mean, it's pretty, buying new shoes, what's the deal here? For a guy, you got to have water gushing in the bottoms before you even consider buying a new shoes, et cetera. It just had not occurred to me. One last thing, and I know people have to go here, just this sort of gender. I play a poker game with a bunch of neighborhood guys, and I have for 20 years. Great guys, and every month we play. 9 months into this game, my wife said, "What does Dick Shumay do for a living?" And I played, 9 games times 12 months, good 100 games, 100 evenings, lots of games, 100 evenings with Dick Shumay. I said, "I don't know." I said, "What do you mean you don't know?" I said, "I don't know what he does." She said, "Well, does he have any kids?" I think so. I know he's mentioned a son, but I don't really know. So she said, "How in the hell do you go through 9 years without knowing what he does and whether he's got any kids?" I said, this is another way. You're trapped. You're screwed, okay? I don't know. Do you talk? Yes. What are you talking about? Stuff. What kind of stuff? Stuff. But obviously not this stuff. Where a man can go for decades and not have a clue about some basic fundamentals on another male, whereas the woman might have picked that up within an hour, sort of the basic fundamentals here. So I actually appreciate the fact that women tolerate the existence of people like me. Between the shoes and a variety of other things, the fact that I've gotten this far is a true miracle. So anyway, I appreciate that, and I apologize for prolonging this thing. But anyway, my dressing abilities are limited.
Thank you very much.